reduction.
So now, so therefore give a time frame, okay?
Yes,
So
ma'am.
now can you get back and tell the time frame, then it's easy for us to recall what is happening. The sequence of events will be easy then.
Sure, ma'am. Sure, ma'am. Yes, sorry, ma'am.
And another important thing in the exam, you will, as Dr. VT and all we have been saying, you will not get time to write all this. So just put a bullet,
Okay.
and put laparoscopic surgery for weight reduction. So
Okay.
you're likely to get questions there. Number one.
Okay, ma'am.
Number two, then you say was detected to have underlying liver disease during surgery. So that means you have to ask some questions there. You understood?
Okay.
And
Yes,
then
ma'am.
number three is jaundice. You don't have to write jaundice, progressive jaundice. Then just put cholestatic. With pain, without pain. That's all. Then the language is good. You have no problem in explaining or expressing your views. So you don't have to wait. You spend more time in examining and thinking in your mind, what are the questions that they're likely to ask at each level? Rather than writing, you will not get time to write. You will not get time to write. Always bullet it, and you will know, like we say, site, then severity, then whether it was increasing, aggravating, relieving. Those standard questions are there. That you put down. I have to mention aggravating, I have to mention relieving, I have to mention fever was there, did the patient have pain, did the patient have chills, that's all. And formulate that as your sentence. No examiner will be checking your answer book. The answer book is just kept by the side and it's sent back to the DMD office. So none of us, we see the answer book only if there's some finding, no? Like you've drawn a liver, you've drawn a spleen, things like that. You understood?
Okay, ma'am.
Dr. VT, your comments? I think that should be the way forward, okay?
Yeah, because they will not get this much time. That's the main problem. So
exactly.
just brief points, bullets, like that. Okay. And in your discuss, you can tell completed sentences, etc., etc. But there again, make it as brief as possible.
Exactly.
Make it brief as possible.
Dr. James and all, please switch off your, please mute, doctor. Please mute. So much of disturbance. So next time when you're presenting on Tuesday, we just want you to put the bullet. And let us see how you're able to formulate the sentence. That's the way forward. And when you see the case in the ward, wherever you're seeing, see that you have your half an hour time alone to set up the whole thing in right perspective. So as you're waiting, you have a lot of time for discussion and what are the questions are likely to be asked. Okay? So Tuesday onwards, it will not be this long sentences and reading. You will be formulating and we will be listening as examiners. All right? Okay, continue. Continue. So you underwent laparoscopic surgery for weight reduction. Okay, then just continue. Diagnosed liver disease, post-op is uneventful. And then now you read it out. Yeah.
Yes, ma'am. Later, he noticed yellowish discoloration of eyes and urine 4.5 months post-surgery, which was insidious in onset and gradually it was increasing in severity.
So for this, you can just put a graph, you just put the date, 20th February, just draw uplifting graph, then put static and then bring it down. That's all. And then you formulate your own statement. It's slowly increasing. If it's abrupt, you draw it like that. If it's slowly increasing, you draw it like that. Then you say it remains static like this. And then you draw an arrow to cam at this time. And then it worsened. And then if ascites came and dropped there. So that's the time of event. That's all that you can write in your case sheet. All right. Okay. What's happening to the slides now?
How many weeks or months after the laparoscopic surgery for jaundice?
4.5 months after the laparoscopic surgery.
That is why you must give the date. Now tell us the date of laparoscopic surgery.
It was in February 2022.
Date.
It was on 10th of February.
So 10th February. So from there on, now 4.5 months later, now give the next date. Now give the next date.
In June. Yes, ma'am. In June around 25th.
Not around. Now it will be 25th of June.
25th of June, ma'am.
June or July. Okay, fine. Okay, we got that.
Yes, ma'am. 25th of June, it developed yellowish discoloration of eyes and urine. So, yellowish discoloration of eyes and urine. Later, he noticed he took a Ayurvedic medication for the jaundice. Later, there was worsening of the jaundice, and also he developed generalized itching of the body, which gradually progressed in the due course. Next slide. There is no history of color stools or abdominal pain. There is no issue of easy fatigability or fever. In July, around July 5th, the patient also noticed abdominal distension, which was insidious in onset. Initially, it was mild and gradually progressed with reduced urine output. Next slide. He consulted the family physician for the same, and around 1 liter of the abdominal the fluid was removed and was treated with IV injections and oral medications to increase the urinary output. Later, a month after the onset of jaundice, that is in July 25th, the patient noticed that he developed altered sleep pattern in the form of the attendants told he was having increased daytime sleepiness and also had irrelevant speech, but was able to do his routine household work. Then he came here for further evaluation and management on 21st of July.
Now, just hold on. Now, what you have to expand is the ascites, okay?
Yes, ma'am.
The ascites needs expansion. So, jaundice needs expansion. Be 100% sure you're dealing with intrahepatic versus extrahepatic. So, you're not expanded on that. You only mentioned about abdominal pain. That is exactly what I said. Moment the patient's jaundice related to surgery, unrelated to surgery, right?
Yes, ma'am.
Yeah. So then related to surgery, just see what all you should mention. Unrelated to surgery, 1 minute. So unrelated to surgery, whether it was prodrome, was he taking alcohol? Was it some medication? So that is what is most important. That has to be expanded in the jaundice because there's come 4.5 months after the onset of jaundice. There's a gap. There's a time frame there where he's been normal. And you have to tell this particular, he was eating well, he was normal, there was weight reduction, however, was back to work, and he felt completely relieved, or was he actually sick with the weight loss? These are the things. Did he develop diarrhea? From that, you get an idea whether it is part of the dumping or is it part of the bilioenteric anastomosis that is causing severe weight loss. So you have to bring in that bariatric surgery effects in the intervening period between Jan or Feb of 2022 and give us that information. He cannot be normal, no? He's lost weight. But what was his quality of life? Give us that, 1 minute. So just give us that information. Once you've given that information, say, well, everything was doing well, everything was fine. He noticed jaundice. Now, jaundice, if it comes abruptly, no, then it is more related to surgery. But if the jaundice has some prodromal, there is some fatigue, there is some fever, there is some arthralgia, and then he develops jaundice, which is progressive, it will give you a feeling that it is unrelated to the surgery. So the jaundice bit has to be emphasized. Give a good description of that, because there's been an underlying surgery for the reduction of the weight. Okay, can there be a stricture at the hepatico-jejunostomy site? Is it possible that the patient has had a CVD stricture? These are the things that should cross your mind. You understand? And you have to mention it was uneventful, everything, and he recovered and went back home the following day, or he went back after 5 days. All that you have to mention. And then give a detailed description of jaundice. Once you finish jaundice related to it, obviously just be related to surgery or unrelated to surgery. So next time you present, improvise on this history. And then during this period of time, he's taken CAM, and then there's been a distension. Now expand on the ascites. This particular ascites, is it nutritional? Due to surgery, he's lost so much weight and therefore he's not eating nutritional. Is it some occlusion and therefore he's developed ascites? There's one more other complication. Or he had an underlying liver disease and now he's present with jaundice like an ACLF. But what was a precipitating factor? So, see, once you expand on this, nothing more can be asked. It has to be one of these only, no? It has to be related or unrelated. Or was he taking alcohol and that precipitated? You didn't give any information at the jaundice. You just mentioned as cholestatic pruritus with no pain. It can be intrahepatic, it can be extrahepatic. Do you understand? So, in this particular case, all the symptoms that you're going to describe will be related to and unrelated to the surgery because it's an event which is occurring 4.5 months after a surgical procedure. and the patient's got an underlying liver disease. And then once you expand on the ascites, then bring in the urine output, edema leg, bring in the breathlessness, all that you want to talk about the ascites, SBP, that can have a mechanical effect on the lungs, bring in that. So just expand and tear apart that abdominal distension. Don't be in a hurry for that patient going to his family physician. I'm not in a hurry at all. Tell us the details of the case. That's most important. You understood? And then when you mention about MHE or encephalopathy, expand. What is it stated? What is it that caused the problem? These are the things that you have to highlight. And then once you finish this, you have to say, antedating the surgery, what was his actual problem? How heavy was his body? Did he undergo an unnecessary bariatric surgery? Or it was a bariatric surgery for a super obese person, or obesity of class 2, all that you have to mention, so that the questions, they will ask you questions and related to the surgery. Okay, so I just stop here. Dr. BT, I want you to comment on this. Just comment on this so that we can move forward.
Okay, then the new symptoms are jaundice, abdominal distension, and altered. Okay, features are matching. So the jaundice part, probably what was missing is the mention of the prodrome. Because prodrome is important, because we should not be taken away by the fact that it is due to Ayurvedic or anything, or already liver disease is there, therefore it is decompensation. No, we have to find out what exactly has caused the decompensation. Therefore, we have to know whether it is an acute insult on the liver, like with the prodrome, like in hepatitis, viral hepatitis, or some other form of hepatitis. So prodrome. Next is we had cholestasis. Therefore, expand on the cholestatic part. Immediately we are interested. Abdominal pain, fever, chills, rigor, all those things. Okay. Then regarding the altered behavior and sleep rhythm, we can also have other like his ability to move around, any abnormal movement which he has noticed, able to eat well, able to handle things, any gait disturbance which family members have noticed. So some expansion on that part also is necessary. Okay, I think we can go ahead.
So a case like this, always related to, unrelated to. Just draw an algorithm. Surgery, related to, symptoms, unrelated. That's all. Then is there an underlying liver disease? So then second component will be underlying liver disease. No? The second component will be underlying liver disease.
Probably we'll get more points after we finish the case and summarize.
Yeah, come, move forward. We're just helping you out to make a good presentation. Okay.
Yeah.
Now just see this, there's no history of so many things. All this has to be linked with the presentation. Come on, continue.
Okay. Actually, there was no history of abdominal pain. There was no history of pedal edema or facial puffiness or breathlessness. Was not there. There is no history of melena or emetemesis. There is no history of jaundice, abdominal distension, or altered sensorium in the past.
No, don't bring in the past, doctor, here. Don't bring in the past here. This is a past history, no? Why are you bringing the past into the present? You understood? This is not, this will not come here. This will come in your past. In the past, there will be no similar complaints. That's it.
Okay, ma'am. There is no issue of chills or palpable lump in the abdomen or endoscopic intervention.
What is the palpable lump that you asked in this patient who's had a bariatric surgery? They will always do a cholecystectomy.
Yes.
Yeah. So once they do a cholecystectomy, then the gallbladder will not be palpable. So what did you ask? Lump. When you ask the question lump, what lump are you discussing? Everything that you speak, at least if I am the examiner, I'll be only picking up only these. Why? Which lump? What
was in your mind when you were telling about palpable lump?
Exactly.
I was thinking whether to roll out intrahepatic and extrahepatic. Extended, significant distance.
The lump, no?
Okay,
so when you tell points which are probably not relevant at that point of time, examiners will jump at you and ask you this question: why did you say that? Why did you say this? Like that, and completely it goes out of hand. So no also should be highly relevant to the case only. It should be absolutely relevant to the case. Not all the no's which are possible. Okay, negative history should be absolutely relevant to the case. Okay, go ahead, please.
And similarly, that past gallstones. Gallstones now is not relevant, no? Whatever surgery is had, a gallstone was that they will remove the gallbladder, no?
Okay.
Are you discussing past history now?
Yeah, sir. I was thinking in the previous
So there is a
episode, which would have caused precipitated events.
story of the past, that confusion should not occur. Okay.
Okay.
Some of the features look like past history, something look descriptive to present illness. So there is a little confusion there. To be clear about things, the current problem and the past illness. Okay.
Okay, sir.
We will allow him to continue, and then
Yeah. I just thought today's presentation will be more on history. Most of the candidates have problem only history. I'm not worried about the diagnosis of this patient. I just want to know whether your approach is right. So we'll just keep holding on to the history, even if you don't complete it. So all right. So just continue. Now psychiatric. Now, why did you ask for that psychiatric disorder?
Psychiatric is involuntary compassion. Because one was the patient told chronic liver disease. So another thing, because the patient is 41-year-old, thinking of any kind of thing, ma'am.
When such things are there, the patient will say, I have the problem, and you see the patient in front of you having involuntary movements. This is exactly what I'm trying to convey. Like today, we saw a patient in the ward. He had classical features of Parkinsonism. So that means when I start with that, how long you have difficulty in movement. That's all. Then it's confirmed that it's Parkinsonism. So in front of you, the patient will have involuntary movements. Then it becomes a present history. Are you understanding?
Yes, ma'am.
Yeah, you got that message? Certain things, like for instance, supposing you see eyes are yellow, but the patient is not coming forth, you can give that information. We see that your eyes are yellow, is your urine high color, and you can start off, even though the patients do not convey any information. You understand?
Okay. Yes, ma'am.
Yeah. Okay, continue. No alcohol consumption. Okay.
No extra alcohol consumption or tobacco use.
Continue.
Past history, patient non-hypertensive since 10 years on medication and is a diabetic since 8 months on oral medication.
So what medications did you ask for hypertension? Which are the medications in hypertension that can cause liver disease? Methyl dopa. Okay.
Methyl dopa.
Earlier they said methyl dopa, and that was one of the causes. Just like ATT, methyl dopa was one other condition which we would always consider as one of the possibilities. Okay, continue.
Okay.
Dr. Manmohan, when you are discussing about past history and medication, it will be ideal if we say he has been on such a medicine for the last many years, and there is no recent change in the type of medicine. Okay. That's important because if the BP is uncontrolled and the patient goes to a doctor and they may prescribe a new drug and he may develop a delay and things will change completely. Okay. And similarly, diabetes, whether it is controlled well, whether a new drug has been added of late. Okay. That will make this much more impressive because we are thinking of the possibility of a delay due to a recent drug. Suppose somebody has been taking for a long time, it is very unlikely that it will be due to those new drugs which have been prescribed in the last 3 months will be the things which will be important in this case. Okay. So please continue.
Okay. For diabetes, since 8 months, he was taking initially insulin. After the bariatric surgery, the patient is changed to oral medications, oral hypoglycemia. Then family history.
Continue.
Father was also very obese and was diagnosed to have chronic liver disease at the age of 60 years. He was on regular treatment for 5 years for liver disease, and he was diagnosed to have liver cancer at the age of 65 years and died due to hematemesis and complications of hematemesis and melena. Father had at the age of 65 years. The father was diabetic and she was hypertensive. He has 2 younger brothers and both of them are young. Next slide.
How are they? Are they also obese?
They are also obese, ma'am. They are also obese.
So bring in that information. Yeah.
Okay.
Bring in that information.
They are also obese.
Yeah, you could even ask a direct question: was he on any hepatitis B treatment? Was he on HCV treatment? Okay, those are the other things that can also cause liver cancer, apart from NAFLD. So you can ask a direct question and just say that there's no further information on any other treatment related to any other infection. For the father.
Okay.
For the father, yeah. And for this, what you should do is don't write all this. Just draw the family tree. Just draw the family tree. Father, mother, draw this and say all are obese. That's it. That's it. You don't have to expand so much on this. Okay, continue.
Okay. Treatment history in the hospital. In the present condition, he is treated with IV medications and supportive measures. Abdominal distension and urine output improved over 3 days. But his sensorium and jaundice continued to worsen during the hospital stay. So he was subjected to 3 cycles of dialysis, he told, and his symptoms gradually improved after the second cycle of the dialysis.
All this will come in your present history, doctor.
Okay.
Not after finishing family history, socioeconomic history, and then come back to the patient and say this was a treatment history is part of your presentation, doctor.
Okay.
Treatment history for all above symptoms. Patient was admitted to this hospital and had further detailed evaluation and also had dialysis, following which what all improved? You have to mention that, no? What are the things that improved?
Initially, abdominal distension and urine output had improved with the medication. The liver dialysis, the altered sensorium and jaundice. Both
you
of
have
them.
To tell, when you say liver dialysis, you'll have to say, was it flex, was it CRRT or SLED? All these questions will be asked.
It was
and all this, you can get the information from the patient as to how it was done.
Okay.
You understand?
Yes.
Yeah. Okay.
He underwent 3 cycles of flex therapy. And his jaundice and altered sensorium improvement.
So if I were to start history, I have to first tell why he underwent the procedure, laparoscopic surgery, bariatric procedure. What was the indication? Was he on did he have the complete protocol evaluation of a patient who's obese? And he went through all the level 1, level 2, level 3 trial, and he did not respond, and then he went for surgery. All this is what you have to discuss in this patient. And say patient was apparently doing well until February. He was on follow-up for obesity from whichever year, and the concern increased when his father died of liver cancer and he was also obese. So he was concerned about his own health, and therefore he sought evaluation. And during the course of evaluation, he was found, you have to mention all this, doctor, and then say he was recommended diet regimen, he was recommended all this. Patient, however, defaulted or he agreed and there was no response. Then they will ask you what any medications were given. He's a diabetic, was saraglitazone given? All these questions will be asked. There's no shortcut to that. It is not on one fine day, he just comes to the hospital and says, I want bariatric surgery. So bring in the beautiful history saying how he was ahead of the surgery, then he underwent surgery, what was the outcome, and then what happened later. Understood?
Okay.
And here, when you say improvement, you have to mention everything. Did the jaundice, only 3 complaints he had. Did the jaundice subside? Number 1. Ascites come down, and did MHE respond? This is what. And was he in ICU? Did he require ICU admission? Did he require oxygen support? These are the things, no, you have to highlight because he is having MHE. This history has to be really torn upon in such a way because you mentioned cholestatic. Now the patient has responded to what? What are the symptoms that have come away? His encephalopathy has come down.
Yes, ma'am.
Ascites has responded to some medication. What about the jaundice?
Jaundice has also subsided, ma'am.
Over what period of time? It's not magical. It's not magical. 2 days you give dialysis and 3rd day the jaundice subsides. Is it possible? It's never possible. The jaundice that you described, bilirubin will be around 25.
Yes,
2 days cycle will bring it down to 18. 4th day it rise back to 25. That's what happens in patients who take CAM. They never disappear. The jaundice never disappears completely. Normalcy. But supposing you say the pruritus subsided, everything settled down, and you became normal and you walked back home, then there's something wrong in the history taking. Okay, you got that?
Yes, ma'am.
So you tell me what are the symptoms he responded to?
With oral medication, distension and urine.
No.
For 3 days.
What was his performance score ahead, and what was the performance score at the time when he recovered after the dialysis?
Performance status before dialysis was more than 50% of the time he was bedridden.
No, give us a score. Yes, 2, 3 or 3, yeah. And now after dialysis?
ECOG 2, ma'am.
So 3 only has come to 2.
Yes.
Okay, these are very important. You have to give us information about the patient so that we can imagine him as you're describing. Okay.
Okay. Yes.
Continue.
So pre-illness nutrition used to, after the surgery, 56 grams of proteins. He consumes 1,250 kilocalories, 42 grams of protein. Actually, his weight is deficient is around 1,500 kilocalories and 40 grams.
But he will be on a low-calorie diet, no?
Low
Because he's
calorie
had bariatric surgery.
Yes, ma'am.
But he's having a near normal diet.
1,250
Has he
calories.
been on this sort of a diet surgery, or is it because of the current illness, jaundice, etc.? He reduced the total intake and protein intake. Is this a reduction in the calorie and protein intake due to the current illness, or has it been like this after the surgery?
After the surgery, he was taking 1,800 kilocalories, sir, and 56 grams of protein. Reduction of that. Now, with the present.
How much does it come to? 30 to 35 kilocalories. What was his diet requirement? 30 to 35 kilocalories per kilogram, or what is 20 to 25 diabetic diet? So give us that information.
His weight is presently 145 kgs, ma'am.
So after surgery, it's 145.
Yes, ma'am.
So before that, he was
175. 175 kgs.
All this you have to mention in your presentation.
Yes, ma'am.
All this you have to mention in your presentation.
Okay, ma'am. Initially, I mentioned 175 to 150 kg had reduced in first 4.5 months, ma'am.
Okay. Personal history.
In personal history, he consumed mixed diet. Altered sleep pattern is bowel and bladder are normal and regular. At present, ECOG score is 2.
Yeah, I just want to re-emphasize once again that this sleep pattern, that means he's come out of coma.
Yes, ma'am.
No? So all sleep and all is part of the patient's, nothing personal about it. Bowel and bladder is also nothing personal about the patient.
Okay.
Okay. So, VT, anything more to be asked in the history? We'll ask Deepak to summarize.
Yeah, I think fairly detailed history. Some points which you are missing, which I think we have highlighted it. You can summarize it.
Yeah, Deepak, you can summarize it, and then we'll ask one more. Summarize.
Yeah.
Without saying the slide, yeah.
Yeah, the 41-year-old male obese came with the complaints of jaundice.
Super obese, no?
Yeah.
BMI, if you have the BMI, you can tell us the BMI. What is the BMI? Above 40?
Yeah, now it is after, now presently 39.5.
So before surgery, so you can calculate the BMI. So it's more than 40. So classify it as obesity class 2 or whatever it is.
Yes.
Okay, continue. Keep up.
Yeah, presented with a jaundice, abdominal distension, and altered sensorium. Sorry, irrelevant speech. Then he has a past history of diabetes and hypertension with the family history positive for excess.
No. Just hold on. That's not the summary, no? Summary, you're just telling the chief complaints. We have discussed so much in detail.
Okay. So,
bring in that he was asymptomatic for the next 4.5 months, and then notice cholestatic jaundice, which was progressive, followed by this onset of ascites, not precipitated by any prodromal symptoms or alternate system of medicine. All this you have to mention.
Yes.
And who was also detected to have an underlying chronic liver disease at surgery. All this has to come in your summary. Don't bring in just the chief complaints like jaundice, ascites, and MHG. That's not the summary, okay?
Yeah, in my 47-year-old man who was very obese and was hypertensive and diabetic for the last many years, underwent bariatric surgery 7 months ago, and an uneventful recovery, and he was on a special diet ever since. 4.5 months, he noticed the present sets of symptoms. Okay, so that gives us some background about the case. And the new symptoms are jaundice, abdominal distension, altered sensorium. With a past history of whatever it is, and the strong family history of liver disease, his father dying of liver cancer in the past. Okay.
And who responded to dialysis complex regimen, which he responded and appears to have moved in from performance stage 3 to performance stage 2 with recovery of hepatic encephalopathy, reduction in the ascites, as well as some response to the intensity of jaundice. This you have to mention. This you have to mention.
Lose consciousness because only altered sleep pattern and incoherent speech or something. Did he really lose consciousness?
No, sir. No loss of consciousness.
No loss of consciousness. Okay.
No, sir.
So, what do you think we're dealing with? Differential. Deepak.
We are dealing with the acute on chronic liver failure. With the acute insult.
You just said dealing with the patient with diabetes. Now give your syndromic diagnosis. Give your complete syndromic diagnosis.
Syndromic diagnosis first, and then you bring in different possibilities related, unrelated to surgery, like that. Okay.
Okay. So 40-year-old male with diabetes and hypertension as comorbidities, with decompensated cirrhosis of liver with portal hypertension. Now, maybe and with a recent history of bariatric surgery 6 months back, and with ECOG status of 2.
Continue.
So
syndromic diagnosis will be post-bariatric surgery.
Post-bariatric.
Okay, that's your first syndromic. Post-bariatric surgery, who's presented with polystatic jaundice with liver cell failure, right?
Yes.
Polystatic jaundice with liver cell failure. We do not know whether it's portal hypertension or what, but there is evidence of a liver cell failure, maybe acidic and anything. Okay, with comorbidity, with a history of CAM intake with the onset of jaundice, polystasis is already there. Comorbidity of diabetes plus hypertension. Okay, and you have to write complications of ascites and HE, comorbidity of diabetes with hypertension with a performance score of 3. That is your complete syndromic diagnosis. And now say, what are the causes, what are the likely causes of this particular patient having the jaundice after 4.5 months of the surgery is what's your discussion. Okay, now tell us what are the differentials for this particular symptom. So diabetes is fixed and a strong family history. That has to come in your syndromic.
Yeah.
With a strong family history of hepatocellular carcinoma. I'm not interested in obesity, but I need to know whether HCC was, because you're trying to conclude that fatty liver was responsible for HCC. Don't come to any conclusions. Don't come to any conclusions. You just say father had hepatocellular carcinoma. That's all. Just stop there. Because if you know the weight of the father, you know the BMI of the father, then you have to mention it. Just saying someone is obese, every person is obese otherwise, no? HCC is an important history in this patient that needs evaluation even in this patient. So that's your syndromic. Now can you discuss what are the possibilities of the jaundice with liver cell failure and HE? What are the possibilities?
So first possibility is acute on chronic liver failure. The acute insult might be a HCC, Budd-Chiari, or drug induced.
Go slow, one by one. 1, 2, 3, 4. Tell your order of priority.
Yeah, for acute insult might be a Budd-Chiari, HCC.
I would tell the examiner, can I discuss a few points on the likely surgery in this patient? I'll first take up that. I'll take up first that issue because the patient would have been told what type of surgery is likely to undertake. The doctor would have drawn a figure and told that this is what you're likely to. So, Manmohan, can you just tell us what was told to him as to what type of surgery is likely to take place? That is the first thing I would like to know. I would first like to know, because suppose it's only sleeve gastrectomy, then they're not going to touch the biliary system. But if they're planning for a bilioenteric and all that, they're going to touch the biliary system. So, in other words, you should know all the types of surgery. You understood? So, if it's only sleeve gastrectomy, it is only sleeve here, and they're not going to touch the biliary system.
Yes, ma'am.
Yeah, so then it is safe. So, the doctor, whoever is a surgeon, would have spoken to the patient and would have told him, this is what you're planning. So, at least to that extent, the patient will be knowledgeable. So, Manmohan, can you just tell us what surgery he underwent?
Yes, ma'am. It was laparoscopic sleeve gastrectomy, ma'am.
Okay,
I told the foot will reduce.
So sleeve gastrectomy would have been there with a normal anatomical passage. So now we are comfortable. That is what I wanted. So now tell in this context, in a person who's had a sleeve gastrectomy, who's now developed jaundice after 4.5 months, what are the possibilities with the liver cell failure? Number one.
Can I tell, ma'am?
Yeah, please. No, not let Deepak.
Yeah, first is the HCC, as per the family history, Bariatric syndrome, and drug-induced.
Deepak, you complete your list of acute insults and we will ask others.
Yeah, tell your list and we'll ask.
Yeah, so
your first is HCC.
HCC, Bariatric, drug-induced.
Drug-induced.
Yeah.
Anything more?
And yeah, that's
okay. Manmohan?
Yes, sir. First would be a steatohepatitis, sir, and weight loss. Then I would like to consider drug-induced liver injury. Then
are you considering steatohepatitis as a cause for acute insult?
Yes, sir.
So acute steatohepatitis. Is that what you mean?
Because with significant weight loss. Then second would be I'd look to consider drug-induced liver injuries.
Okay, next.
Third is HCC, hepatocellular carcinoma. Then still I'd like to consider Bariatric syndrome. Lord.
Harish, your differentials.
First, my first differential would be drug-induced hepatitis, ma'am. I would also consider hepatocellular carcinoma. Third differential would be Bariatric. I will also think of viral hepatitis as a possibility.
Viral hepatitis, which virus?
C can present with cholestatic jaundice, ma'am.
Not B, not B.
B also can cause, ma'am. After the. Yes.
Does he have a risk factor
not
for
A.
viral hepatitis?
He doesn't have any risk factor.
No risk factor.
Now can take up one by one. Just take up one by one. Karthikeyan, yeah. Now they're all telling about this drug-induced liver injury in this patient as a first differential. Comment on this. What about the surgical causes? Don't want to touch surgery at all, no? Cholestatic jaundice in this patient. No. Other important thing. Do you think you're dealing with intrahepatic or extrahepatic? Karthik? You're muted. You're muted.
It is looking like an intrahepatic cholestasis, madam.
Based on?
Rather, because patient doesn't have any pain, abdominal pain, and also patient don't have any fever associated with the chills.
So what do you think? What do you think is the cause of intrahepatic cholestasis?
Okay.
Now, intrahepatic cholestasis, the cause could be patient might have any liver lesions in the form of HCC. That could be one of the cause, and any reactivation of hepatitis B or hepatitis C could be the cause of the intrahepatic cholestasis also, ma'am. And
so underlying, so possibilities he has an underlying NAFLD, right?
Yes, ma'am.
So that is the first thing you'll have to mention. Underlying NAFLD with diabetes and hypertension in an obese person, NAFLD is one of the basic pathology in the liver is likely to have. Okay?
Yes.
Yeah, so that's number one. In this background, on what basis are you saying that he has a drug-induced liver injury first?
In this patient, drug-induced liver injury are unlikely, ma'am, because this CAM intake is a later. After developing jaundice, he started on the CAM intake. So I won't consider as a drug-induced is the possibility, ma'am.
Absolutely. Yeah. So drug-induced liver injury will not come as important DD unless the diabetic drug that he's had, which was introduced 6 months back, has caused some problem. But otherwise, DILI will not come as an initial DD in this particular patient. The other two people who consider DILI, can you justify and support why you consider DILI? Manmohan and Deepak and Harish.
After initiation of the drug, there is worsening of the symptoms.
That's okay, but what initiated the jaundice? What initiated the jaundice is what we're concerned. We're not concerned what happened after the jaundice occurred.
Yeah, that worsening would be the natural history of the illness. Okay. We can progress, no? irrespective of the fact that whether he has developed CAM or not. Second thing, the jaundice occurred prior to him taking the CAM. Okay, so that every time the patient takes CAM, means most of the patients take some CAM for jaundice. Okay, so after the onset of jaundice, he has taken the CAM. It might have worsened it, we do not know, but I think we can attribute it as the primary cause for the current version. So that's so I will find it little difficult to accept delay.
Okay.
With this
Sir, can we consider the protein supplements or something is taken before the bariatric surgery? The diet changes in the before bariatric surgery, he might have taken the medications.
That's okay, but 4.5 months have passed by, no? Unless he's on herbals, unless he's on some herbal preparation, we do not know. That has to come out in history.
Yeah, if the person will take some herbal preparation or natural preparation to bring in weight, to bring in reduction of weight, that has to be pointed out in the history. The absence of it will be difficult to accept. You just can't diagnose delay out of nothing. If you are nothing, you will come very low in the list, not as a first diagnosis. That's the issue.
Agree.
Okay.
How do you define HCC?
Second differential was HCC. Now, one or each one. One moment.
Yes, ma'am. Because there is a sudden worsening of the patient was asymptomatic for 4.5 months. Then there is sudden onset of jaundice and worsening of liver function in the form of hepatitis.
And he's responded to the treatment. And he would have had a CT scan ahead of the surgery.
Yes, ma'am.
He would have 100% he would have had a surgery to check the volume, etc., because he's underlying chronic liver disease. He would have also been warned with the CT scan that you're likely to undergo liver cell failure after surgery. It's not uncommon, even a simple cholecystectomy. A simple cholecystectomy can cause liver cell failure soon after if they do a complete cholecystectomy. Therefore, they always do a partial cholecystectomy or a cholecystostomy. And mind you, a person undergoing an underlying liver disease and going for a bariatric surgery, I would have expected him to fail soon after surgery. The laparoscopy was done under GA or under spinal?
Ma'am, at this point, the student might get a question regarding the risk of surgery in a patient with cirrhosis.
Absolutely.
That question will be because according to the type of surgery, according to the emergency or elective, and depending upon the liver condition, the risks are described. Okay. So this patient had no problem after surgery. It's a major surgery, no problem after surgery.
And was it under spinal or under GA? Very important because if it was done under GA, 100% this fellow would have had an ascites soon after surgery if he's had an underlying chronic liver disease. Even a simple cholecystectomy causes ascites within the next 48 hours after surgery. Surgeons never take a risk of taking any case for surgery in a patient with underlying chronic, including umbilical hernia repair. Including umbilical hernia repair, you get a fall because they're all the GA. Yes,
the surgeon will not advance liver disease, number one. Advanced liver disease. They will try to assess the patient, and if the patient has advanced liver disease, they won't take up for surgery. That's the main thing. Second thing, an HCC would have been detected, and if a significant HCC was there also, patient will not be taken up for obesity surgery. So this patient probably didn't have any HCC, no big HCC, definitely. No significant liver decompensation. Probably he was in perfect child age, and he remained so until recently.
Yeah.
So a person who did not decompensate after surgery for 4.5 months remained very well and suddenly has recompensated.
Yes, sir.
So it will be difficult because it's not a first symptom of HCC. It suddenly deteriorated. In a liver disease patient, that such a thing happens. We all know that. Okay, but this person is under the eyes of the doctor. They would have thoroughly investigated him, and they would not have missed an HCC. That is our assumption.
Including hepatitis B and C. Including B and C, they would have evaluated. That also would be negative.
Yeah.
No? So you're left only with A and E. So you're left only with A and E. Is it an acute A or acute E? That is important. Sporadic E.
Is it possible that it could be hepatitis? Is it possible that it could be acute viral hepatitis A or E?
Yeah.
Yes, sir, it's possible. Or the underlying liver disease, A or E would have caused the acute insult, which would decompose.
Or it can also be a reactivation of a hepatitis occult HBV. Okay, just keep that in mind. If the person has occult HBV, they can also have a reactivation. So B can also come in the picture. What is unlikely is a C. Okay? But underlying liver disease, is it the incubation period for a C? Now tell that. Can you discuss that? What will be the incubation period for a C between surgery and now?
Usually it is 180 days, about 180 days, ma'am, 6 months.
So it's about 3 months. So it's coming around 4.5 months. So it could be acute hep C, which may not have prodromal symptoms at all. So underlying chronic liver disease, if he's received transfusion, you have to tell that. You have to mention that, whether he received transfusion. These are the things that you have to highlight. All this you have to mention. Surgery, you can mention. Transfusion. So it's, to me, it will be viral hepatitis #1. In that, I'll take A, E, and I'll also consider other possibilities. Plus, maybe a dengue fever. There's a lot of dengue around. Maybe it was just a transient dengue fever. It could be a scrub typhus. All these will just manifest with little fever, and they'll have jaundice, they'll have transient decompensation, and then they recover completely with a plex. So infections will come as a DD. In that virus, I would consider first. I would consider other infections also as my first differential in this patient. Okay. Okay, so HCC, I will not consider at all at this juncture because you would have a detailed evaluation. And if they found an underlying liver disease at surgery, it is just a surface nodularity. There's nothing great about it. It may have been noticed on the CT scan. It also tells us that unlikely that he's had a portal vein thrombosis because all this will have been done as a CT ahead of surgery. But nothing prevents him from having a thrombotic state now. And he may be having a thrombosis, and he may just be having a transient decompensation, acute thrombosis, and he's settling down. Now, why did you consider HBOTU? Why did you consider bacteria in this patient? Deepak.
That can explain the decompensation.
No. Mechanism. Tell us the mechanism of bacteria in this patient. No? Why should he get a hepatic?
He's an obese patient, non-CLD patient.
So what?
So obese patient has a hyperestrogenic state. So they have.
How often have you seen this, doctor? Super obese people presenting as bacteria. Is it one of the etiology causes? No. It's a prothrombotic fail. This particular patient, ascites, this thing, DD can come, but then not. It cannot be the first manifestation. Okay. Can it be a veno-occlusive disease? Again, just possible. But see, without the drug history, all these I would really not consider. To me, it's liver failure, one due to infection, unknown drug-induced, which we do not know whether he's taking or not. These are my, I will not plunge into a HCC. I will not plunge into a DE. So to me, it will just hang around this. Related to surgery, the CBD has not been touched. Did he have gallstones as, in the pre-operative period?
No, ma'am. He didn't have gallstone.
Gallstone. So no gallstone. So, but if there is an incidental gallstone, then gallstone can present like this.
Yes.
Okay. So what was your third diagnosis?
Ma'am, can we consider, because with rapid weight of steatohepatitis, ma'am, significant.
Yeah, we do get this post-TPN. We do get something like Indian childhood cirrhosis like, but they're all in patient bilioenteric type of, not with sleeve gastrectomy. With sleeve gastrectomy, we don't get this type of sudden onset of liver cell failure like. And that, I mean, I've not heard of it, so I would not know. Dr. Viti?
Yeah, this patient gave a history of sleeve gastrectomy. Otherwise, this case they would have discussed all about biliary enteric anastomosis and complications, etc. Okay, so you must be ready to answer all those things. Luckily for you, that surgery was sleeve gastrectomy. Otherwise, the discussion about entirely turned in a totally different direction and areas which we are not very strong. Okay, so complication we seldom come across and we may not be very strong. I still want to ask that question. Is it still possible that he would have developed hepatitis B or C during surgery? What are the different modes of getting hepatitis B and C in relation to the surgical procedure?
Still B and C.
Yes, because it can be due to needle
Be very see, nowadays most of the it is practically impossible to transmit because blood is screened, all the instruments used are properly sterilized or throw away, single use and throw away, you know. But still, there could be possible that something may be reused, or there is another possibility. Unfortunately, some of the surgeons do not
Surgeons may be positive.
DSC status. They are at an extremely high risk. In youth and all, it is very mandatory that their status is checked every now and then. But unfortunately, except in corporate hospital where a regular medical checkup is done, most of the other places this thing is not done. Therefore, it could be a needle, the needle injuring the surgeon.
Agree.
So that is possible.
So the bet is more towards B and C or an A and E. That's my bet. Yeah.
Ma'am, actually,
and other thing, as you said, starvation. No, starvation can it cause? This is something that has been described. Or post-TPN that can also cause cholestatic jaundice. You know, transient underlying chronic liver disease, they can have a transient failure and then they recover post that. Okay, but in this patient there was no TPN, there was nothing like that, and he was not undernourished. He continues to be well nourished. No? This thing has not come down to that extent that one would have expected.
Yes,
and another important thing is please learn to draw the figures. Okay, they'll ask you to draw sleeve, they'll ask you to draw bioenteric. See that you know the diagrams. Okay, how to draw the surgical procedures. Can we just move on?
There was some question. I can't find it out. Can you read it, ma'am?
I think we'll take the questions at the end. We'll just move on.
No, this person, if you are enthusiastic regarding weight.
1 minute. ACLF as a syndromic diagnosis, yes, you can, but we do not know what is precipitating it. Okay. Yes.
The most
should be mentioned for BMI. In this particular patient, BMI has to be mentioned because we need to know whether he was super obese, how obese he was, and if it's known to the patient. If he does not know, then you can ask what was his weight, you can calculate the height, and then you can calculate the BMI. It's very easy. You just need to know his weight. The patient is in front of you, take the height and mention his BMI approximately prior to surgery was so much as calculated from his height and his knowledge of the weight. Okay. NASH-related decompensated liver disease caused at the time of LSCG. The CT scan was suggestive of liver disease. And what is the LSCG? Laparoscopic sleeve gastrectomy. Okay. Why can't it be NASH-related? It can't, because there's a 4.5 months gap between the surgery and the decompensation. That's why they're not linking up the surgery to the decompensation. That's the reason. We have just discussed that in detail. Post-cholecystectomy, post-umbilical hernia, post any major surgery, underlying liver disease, plus is decompensation. That's why surgeons are always wary of touching of these patients. Okay, recently we had a patient who has underlying chronic liver disease, is coming with recurrent acute cholecystitis, but Doppler is showing vessels around the gallbladder. Surgeons don't want to touch it. They don't want to touch the patient. So we are planning for an ultrasound guided to get between the vein and do a cholecystostomy. They don't want to touch the patient. Patient is in CTPA, but liver is showing cirrhosis on CT scan. They will not touch the patient. Okay, so actually these events occur immediately. They occur soon after surgery, within 24 to 48 hours. Okay.
Okay. Actually, for chronic liver disease, man.
What is the cause of liver disease in this patient?
Yeah, what is the cause of chronic liver disease in this patient?
One is NAFLD related.
NAFLD, NASH-related cirrhosis.
Then second, it can be still occult hepatitis. So chronic viral hepatitis can be second.
Don't use the word chronic viral hepatitis and all these terminologies are all. Where are you getting? You should not use all these chronic viral hepatitis. You say chronic hepatotropic virus infection or something like that. In that, B and C will come in. A and E will not come in.
Okay.
Don't use these words like chronic viral hepatitis and all that. There is such, I mean, you should never use such terminologies, okay? Examiners can be very tough, I'm telling you.
I think this BRC infection would have been detected prior to the surgery, and patient would have been told about the need for treatment. So that's probably was not there. Occult? Okay, we can accept. Unless surgeon may not look for DNA and all those things, if HbA is negative, so that is possible. Okay.
And what you said, VG, you also mentioned, no, post-operative is an incubation period. You could have acquired a new infection.
Yes, ma'am.
Yeah, you could have acquired. Supposing you suddenly find AST, ALTs in thousands, then we know that it's acute. Nothing prevents him from getting an acute. He may be negative, not vaccinated, and he gets an acute infection, per-operative and post-operative. Okay?
Okay.
This would just be my difference here.
Apart from this obesity, he doesn't seem to have other risk factors for chronic liver disease. Okay, that is most likely cause for chronic liver disease is NAFLD.
Yes.
There's not much of discussion in that direction. Mostly it will be the cause of acute insult. Most of the discussion will be in that direction. Okay. Can we proceed further, ma'am?
Yeah, please. Yeah. And whatever was insult caused ACLF-like presentation with transient ascites and encephalopathy with a CAM superimposed. Whatever the plex did was just allowed you to take off the CAM component and the patient took it. Okay? Okay. On examination?
Yes, ma'am. On examination, our patient is a 41-year-old male, morbidly obese, with a BMI of 39.5, is conscious, cooperative, and oriented to time, place, and person at the time of examination. His right skin fold thickness was 16 millimeters, and mid-abdomen was 33 centimeters. He examination, no pale cyanosis, clubbing, or lymphadenopathy.
Don't use the word, doctor, in this patient, don't use cyanosis, clubbing, and all that. Okay.
Okay.
If you're very particular about HPS or POPH or something, you mention that. Otherwise, don't mention that. And in the patient, intense jaundice, don't come into a pallor. Never come into a pallor.
Manmohan, is it corrected BMI?
Sir, at present, actually, no, sir. No pedal edema, sir. So it's the normal BMI, sir, not corrected BMI.
Okay.
Yes, sir. So, features of liver cell failure in the form of patient is icteric, and we have large axillary ears. There were scratch marks which are visible over the abdomen and extremities. There were no xanthomas or other ecchymotic patches and bite outs.
Now, in a given patient like this, when do you expect that? How many patients have you seen presenting with 6 weeks of jaundice or 4 weeks of jaundice, polystasis, developing xanthoma, xanthelasmas? They're all in PSCs, not in this type of a jaundice. Do not comment. I would ask you, did you waste your time looking for xanthomas? Don't comment on all this. Don't comment on xanthomas and xanthelasmas. I'm telling you, the examiner, no, they will catch that point. They're waiting to capture the points that you're making mistaken and ensure that you're thinking of the right thing in the right direction.
Like in the history, the negative on physical findings also should be relevant to the case. You should distract too much from the case. Okay, fine.
Okay, continue.
Vitals were normal, ma'am. Pulse was 80. JP was not elevated. Hepatitis jugular reflex was present. Next slide. Inspection. Abdomen was protuberant. Umbilicus was central and inverted, and flanks were free. Then there were scratch marks visible over the abdomen. Then
just tell the positive findings.
Only scar over the abdomen was there due to the laparoscopic port sites, and there are no dilated veins in the palpation. It was normal, ma'am. Liver dullness. Nothing.
Ascites?
No, ma'am. No ascites, ma'am. No. Ascites.
So liver not palpable. Liver span.
Next, liver span is 10 centimeters, ma'am.
Liver span is 10 centimeters. Spleen not palpable. No free fluid.
No free fluid. But drop space was dull on percussion, ma'am. Next.
Very difficult in such an obese patient to pick up drop space dullness, doctor.
Okay.
This man is so obese. He is one huge fellow who's occupying the whole bed. Where are you going to percuss for a chalk space? You just say chalk space could not be elicited. Morbid obesity, the chest will be so heavy. You cannot do this. And I'm sure you would not have done it also, okay? Will you spend your time looking for a chalk space in this patient for a spleen? I would really not spend my time. Okay. So when you examined him, there was no ascites, is it?
Yes, ma'am.
So you saw him after the plex, right? So in your history, you have to mention that you're presenting a case post-plex, no? So then the discussion will be pre-plex. The discussion is all pre-plex, nothing post-plex, no? Right?
Okay. Yeah, ma'am.
Yeah, right
Okay.
now he's stable and everything
It's
is normal. Icterus, what about jaundice?
still is icteric.
So icterus is present. Okay.
Deeply
Scratch
icteric.
marks, itching is less. Itch is less.
Yes, ma'am. Itching is radial, but still scratch marks over the generalized itching. Scratch marks are
Okay.
present.
Okay, fine. Okay, continue.
Next slide.
Okay, continue.
So, percussion
move on.
and
Next, don't do rectal examination in all such patients, for heaven's sake.
okay.
It's totally
Next
irrelevant. Don't do all that. Okay, respiratory system, cardiovascular, nothing. Everything normal.
Nothing. Everything was normal.
Okay.
Never.
MHE?
Sorry, ma'am.
MHE? Minimal hepatic activity.
No features of minimal
He had history of sensorium. Obviously, he had some sort of encephalopathy, and now he's recovered. But still, you have to look for features of minimal hepatic encephalopathy. So, what are the tests you would do at bedside?
Number connection test, sir. Then, this thing, connecting dot test, sir.
Please read about
connecting dot test.
R.K. Dimon's figure connection test A and B. FC A and B.
Which may not be available in the ward, like figure connection test, this, that, and may not be available in the ward. Even number connection, you have to have the chart. Okay,
yes,
so usually you are not permitted to carry the chart. Only if it's available with the skilled assistant, if you ask for it, if they give it, you do it. You cannot bring in yours. Okay, so that's very important. Don't try to bring in all those charts and use your thing, because that's not allowed in the examination.
Okay, sir.
Including the Stroop test and all. Don't use your mobile and all. Okay, don't, please, for heaven's sake, don't do all that.
Yeah. Unless you are very particular, ask for permission and then only do. But don't use your mobile as Stroop test, because they will not be happy at all.
The registrar who's moving around, you can ask him, do you have a permission for doing a number connection test, or do you have a retained chart trail test? Just ask them. If it's not there, then you mention in your examination, I'd ask for these, but these are. But simple thing that you can do is ask the patient to sign. If they have a micrographia, it starts with a big A and then goes to a small a, that is sufficient. Drawing a star is difficult even for us. So drawing a star is okay. You can mention it. But simplest test is micrographia, just asking him to sign. You'll find that it starts with a big and it goes down. And as Dr. Viti mentioned, please, for heaven's sake, don't take your mobile and say Stroop test was negative, or you did a number connection test and carried it in your pocket. Don't do all those mistakes, okay? But you can ask the registrar in the ward, do you have? Some of the centers do have all this. Like if you go to AIG has got percentile chart for the pediatrics. They have they have all the charts, retained trail test. They have the figure connection test. Everything is available. So centers which have it, you can ask them, do you have it? And then say, I asked for it. They gave me the chart and I did the test. And most important thing is, in all these tests, you have to take two identical people with the same literacy status. Be very careful. You cannot compare yourself with the patient. If the patient is studied up to 8th standard, you have to collect one more person control from the ward who's also studied up to 8th and match those two for the time taken to do the number connection. Have you understood? You should not compare two different literacy status for any of these tests. Have you got it? Yeah. These are few important messages as far as examination is concerned. What is the gate? Gate. Not that. Very important. You have to get the gate. You must do the gate, okay? And visible veins were there?
No, ma'am, no visible veins.
No visible veins, okay. So you have to, do not miss on the gate. Because whether he has cerebellar signs, whether he has any other signs, so just see that the gate is also taken care of. Okay. So what's your diagnosis at the end? Deepak, what do you think is a possible diagnosis at the end? It remains the same.
See, it remains the same. Syndromic diagnosis.
There's not much of that's what I said. History will allow you to get 80%. Examination has not contributed to anything except that patient has responded to the plex, post-plex. So in your diagnosis, you have to mention that post-plex response. In your syndromic diagnosis, you have to mention that because you're seeing the patient post-plex. These are all very simple things, but you have to mention status, post-sleeve gastrectomy, post-plex, and then pre-plex, what was your diagnosis? That's what you have to mention.
Okay.
Okay, be very careful about this.
Among the differential diagnosis mentioned by you and others, which are the ones which are likely to respond to plex?
Drug-induced liver injury responded to therapy, sir.
Okay, disease can. Hepatitis.
Hepatitis.
Liver injury. Okay, so the first diagnosis HCC, second was Bariatric. Do you think these entities will respond remarkably to?
They will not respond. They will not respond.
Okay. So that history also is relevant when you make your list of differential diagnosis. You haven't got the test. Okay. Let them discuss it.
So what would have happened is he's had an acute hepatitis, one of the infections. So whatever the Hex has done is just remove the CAM component. That's all. That's why the jaundice is persisting. The CAM component is gone, but the jaundice is persisting. So what do you think is the cause of jaundice now? Bilirubinostasis?
Still like acute viral hepatotropic.
Polystatic. It can still be CAM. It can still be CAM with NAFLD, NASH-related cirrhosis, with CAM with the underlying liver disease.
Liver disease.
Yeah, that is reactivation of the hepatitis or new onset of acute, because he's not crossed the 6 weeks, no? We are still in the polystatic phase of a viral hepatitis.
Yes,
as per your discussion. Okay, so can we have the reports now? Reddy, you can take up now. Move on.
Yes,
Reddy, take up the investigations. Come on, quick.
Patient hemoglobin on 21 July,
no, 9.7. Let's give the overall picture. So hemoglobin is low.
Hemoglobin is 9.9 and total leukocyte count is 8,500. Platelet count is initially 47,000, 1,21,000 later.
So what's your interpretation? What's your interpretation of the platelet count?
Patient maybe during acute insult of the liver, platelet count might be low. After maybe post-plex,
no, doctor, this tells you he's got an underlying chronic liver disease.
Portal hypertension is
that's
there.
All. That's all. It tells you he's got an underlying chronic liver disease. Very simple.
Yes. Yes.
Okay, platelet count is uniformly low. What we need is a platelet count before surgery. That we don't have.
Or is it due to some illnesses which reduce the platelet count and it improved automatically? We discussed maybe other entities for acute peritoneal liver injury, no?
Yes, yes.
What are other infection which can bring down the platelet count?
Which are the infections? Infection that can bring down the platelet and respond.
Dengue fever.
Malaria.
Many of the viral, most of the viral infections, they'll have a drop and then they'll come back. So that is one possibility.
Total bilirubin initially 25.89 and later decreased to 14.2, man. Okay. Directors to 22.8 and now it's 11.8. It's a conjugated direct hyperbilirubinemia, suggestive of obstructive jaundice.
Not
mostly,
obstructive,
cholestatic jaundice could be mostly intrahepatic cholestasis, ma'am.
Yeah, that's right. Because why do you say intrahepatic? Alphos is normal.
Alphos. AST is 103 initially and later 77. ALT is 67, later 32, ma'am. And alkaline phosphatase is 136 and 110, looking like normal. And total protein 6.7, 5.8. Albumin is initially 2.7. Later it is 3.9. Maybe patient was transfused with the albumins during the hospital stay, ma'am.
Yeah, post-plex also.
Post-plex. Yes, ma'am.
Other thing is the transient infection caused liver cell failure, and he's just reverting to CTPA. He's just coming back to CTPA. That's only likely. He's just coming back. What is it called? Recompensation of.
Recompensation of the.
Now you can use that. Now you can use that word. You have the Bevino 7. You can mention the bracket. You should write Bevino 7. Recompensation of a decompensated liver disease. He's coming back to total normalcy, except that bilirubin is high. But by definition of recompensation, you should have everything normal for at least, I think, 6 months or 1 year. Everything should become normal. That is, platelet should be normal, the liver should be normal, enzyme should be normal, albumin should be normal. So it may not be true sense recompensation, but there seems to be a shift from CTP-B to a CTP-A. That much you can always mention. Okay. You can always mention there. All right. Okay, next move on.
Yes.
Yeah.
INR is
creatinine is normal, sodium is normal, potassium. Now come to specific investigations. Here it is. Now you got your see. We didn't know that.
HbSAg is positive.
HbSAg, very good.
And E antigen is a low positive. IgM core also positive.
Positive.
So yes, ma'am. And quantitative
is exactly what I said. See, your history made the diagnosis. No, we had nothing to do. We were only waiting for this viruses. Both of us were waiting only for this information. We were very clear. It's not Delhi, it's not Bad Kyari, it's not HCC. We were very clear because the presentation was not like that. You understood? So we expected a B or a C to come up, or an A or an E. But only thing is, what is striking here when you say it is acute B?
IgM core is positive.
Enzymes are not high.
Enzymes are not high. Yes.
Enzymes
10.
are,
yes.
Except that maybe he came a little later. He may have come a little later when everything subsided, and he's come at a phase when he's resolving. Okay. Now, now what should you do next? Any further? 1 minute. Any further investigations you want?
I will do other ascitic fluid analysis also. Just
no
to
ascites
rule out.
now. No ascites. Everything
No.
gone.
What? Now, do you think this hepatitis B is due to surgery, or was it presenting earlier? Is there any clue in the history that it is possibly that was there in the family?
That's why I asked. HCC, no?
Father has HCC, so
that's why I asked.
patient.
So I asked that time, did you ask the history whether the patient received treatment?
What is father to son? Is it possible?
Father to son. Is it horizontal or vertical?
Possible.
It's a horizontal transmission.
Yeah. In fact, our study has shown father to son was most likely rather than mother to children.
Mother, yes.
Yeah, it was a funny observation. But for anybody who is HIV positive or HPV positive during their first 1 year, any children or anybody living under one roof, anybody can be the source, anybody can be the recipient. Okay. So let's say it may not be father, mother, brother, sister, anybody living under the same roof. Okay, is enough. Okay, go ahead.
So what do you want next? Just hold on. What's the next thing you want? So one is you got an information. How will you define? What will be your diagnosis at this stage? The latest classification: E antigen positive. E antigen positive, chronic HBV hepatitis.
Hepatitis, ma'am.
Yeah, that's your
transaminase is also there. Hepatitis.
That's right, hepatitis. So it is. So you would say my diagnosis at this stage is E antigen positive, chronic
with the chronic
HBV
hepatitis.
HBV hepatitis, exactly. Okay, that's a final. This is the latest classification. So anything else you want in this patient for follow-up? What's the next thing you want? What should you do now?
We can start
you need a baseline imaging. You need a baseline imaging.
Ultrasound abdomen I will do.
You will ask for a baseline CT. If you have already and you can review the CT, that is sufficient. I would not ask for once again. But if it's not there, ask for a baseline CT and ask for a baseline alpha-fetoprotein.
Alpha-fetoprotein, AFP and CT.
Yeah, these are the few things that you need in addition to what we have. And an upper GI endoscopy. You will need an upper GI endoscopy for any presence of clinically significant portal hypertension. Whether the patient has clinically significant portal hypertension. So based on the platelet count, it indicates that the person has got significant fibrosis.
Portal hypertension.
So what are the predictors? What do you think would be the endoscopy report in this patient? So these are all the Bevino. Please read Bevino 7. Would you like to do an endoscopy in this patient to pick up the varices? Or you would say, I don't need one. I don't need an endoscopy. I can predict that this patient will be having varices. So what is Bevino 7?
We can predict esophageal varices in this patient as per Bevino 7 because platelet count is low.
Low. So therefore, that's what the AVPG. So you must know what Dr. Sarin's, now they have less than 10 subclinical, between 10 and 12 is a clinically significant, and they've subdivided now as 5 to 8 and 8 to 10 the recent in ASIN 2022. Okay, there's a further division there. So when he says it is less than 8, he's almost certain that there'll be no portal hypertension. But between 8 and 10, he still feels that the likelihood of portal hypertension varices is present. Please read Bevino 7 A to Z. All right. So can we have some imaging information?
Excellent.
Can you just tell doctor everything? Chronic liver disease, mild ascites, no evidence of portal vein thrombosis. Okay, next.
Portal vein thrombosis.
Next. Why do you want an MRCP? Why was an MRCP done?
When CT was not available. So
CT was not available. Okay, but it was just for that polystatic jaundice. Okay, accepted.
polystatic jaundice.
Do you want any further? Harish, can you take up the discussion on management?
This one. This patient, we have to start on the oral antiviral drug. I would, first thing will be we can start him on.
Don't say you can start him off. I will start. All these things are very, very critical in the exam. Be very careful. You know, you will just get ticked off by this and you'll say, oh God, what the hell is happening? I'm telling you.
Okay.
This is exactly what happens. So I will start. It is you and the patient.
Yes, ma'am. I will start the patient on either tenofovir.
No. What will you start, doctor? You may not ask him either this or that. He is your patient. What will you start?
I will start tenofovir 300 mg orally, OD dose, and then monitor his viral load after ALT, like LFT in the form of AST and ALT, and also viral load subsequently over the next 3 months.
Why do you want to monitor AST ALT in this patient? And first, at a few questions, you'll have to tell why you're not choosing entecavir, why you're choosing tenofovir, why are you not choosing TAF. Okay? Dr. VT, I would like you to just take up this discussion on management, please.
Ma'am, this patient has no renal failure, so we can go ahead with tenofovir, bisproxavir.
That's okay, you can tenofovir, because when you start, you have to see whether there's any risk factor, risk for the drug to produce problem. Okay, renal functions are the most important. It doesn't have.
Yes,
okay, at the moment, creatinine is okay, no? That's what you're concerned. If creatinine was at any time higher, or there is any common risk for there is no renal involvement whatsoever, whether it is due to liver disease or primary renal, okay.
Then we have to consider either TAF or entecavir. We can switch to either. Then we have to, as the patient responded to diuretics, we have to.
I just want to know, till date, I've never started any patient on tenofovir. For me, the choice is always entecavir. So can you justify? Am I wrong in starting an entecavir? Why should I choose? I have a backup of tenofovir for resistance if I get. But after tenofovir, I have no upfront drug to help me in management. So all my patients are only on entecavir. And so far, I've had no problem. So can you justify why you want to choose tenofovir, not entecavir?
Between entecavir and tenofovir, which one seems to be more safe?
Entecavir is more safer.
Obviously safer. This patient obviously had some sort of a failure, you know. But in possibly renal failure, we have not much idea because what happened during the plex channel, we have no idea. But it is possible that there could have been some renal dysfunction. Okay. So I think the safest bet would be entecavir.
Okay, sir.
Safest bet. That is how you have to think. Okay. Among all the drugs, which are the ones which is least likely to produce least damage in these patients, but already had a recent acute decompensation event. Okay.
Yes, sir.
The next question is entecavir 0.5.
As this patient has
0.5 to 1 milligram. What is your justification?
Ma'am, this patient has already a background chronic liver disease, probably now cirrhosis. Now that's why we have to give 1 mg for this patient.
Where do you get this information from? Which guidelines? You have to quote the guidelines, doctor.
1 mg.
Which guidelines are you quoting that if a person has cirrhosis, you give 1 milligram and otherwise you give 0.5?
I'm not sure about the guidelines, ma'am.
That is important.
What is the difference between a person with no cirrhosis and with cirrhosis and HBV, which you are planning to give oral medication? So what is the difference? How long will you give?
Sir, for a patient of cirrhosis, we have to give lifelong.
Okay, so that is the difference, no?
Yes.
Yeah. So when you start itself, you have to tell the patient, and during the therapy, you have to monitor. Is there any reason to monitor? Hepatitis, if you are going to give it lifelong, so you may as well give and forget about it. No? So is there a need to monitor reduction in HBV DNA?
Sorry, sir, I didn't get your question, sir.
You have to monitor. You have to monitor this patient for HBV DNA.
Yes, sir.
You have to respond to the drug.
Yes, sir. We will repeat the HBV DNA levels after 3 months and see if they're coming down. Like there is a response to the antiviral.
What do you expect?
Usually the respond none. The levels will come down. They'll be less than in case of.
Harish, but when you speak all this, no, you have it is with the confidence that you're speaking.
How many log reduction will be there? That's the question.
That is how you answer. Yeah.
2 log reduction.
Minimum of 2 log. Yes.
A minimum of 2 log reduction should be there. Next question obviously will be how to calculate the log reduction.
Yeah.
So we will not let you read up. And
Yes.
the next, okay, so you periodically check up the DNA and anything else you have to do in this patient. So just give
We have to also periodically check the serum AFP levels, and imaging also has to be done. Screen HCC.
What imaging?
We can do it. Hey, Harish, please speak properly. This is what you do at your day-to-day practice. You will say 6 monthly. I'll be asking
ultrasound
for a puncture test. I'll do a CBC, and I'll get an ultrasound with an alpha fetoprotein at 6 monthly interval. Then the questions from here will be taken off. They'll take questions from here on. They'll ask other questions from here on. Okay, so that's how the Viva will move on. Okay. Now, anything else in this patient?
One is the current problem. Okay, we only give other symptomatic measures. We have no specific medication to bring down the bilirubin. We have to observe the patient. Yes, he might have responded to flex. So we have to keep the person under observation. We want to know whether he's decompensating once he goes home. So he has to be called for a follow-up. Maybe a 1 month later to see whether ascites is worsening, etc. In which case, you will have to add on diuretics as well. Okay. Another thing, all hepatitis B patients, you have to do family screening and then give appropriate advice depending upon whether they are negative or whether they are vaccinated. If they are positive, then you have to find stage of the disease and treat. Okay. So family screening and appropriate action is a mandatory thing in all patients with hepatitis B infection. So you should not forget it.
And look for his E antigen becoming negative. No? E antigen positive becoming negative. And all the other questions, HBsAg quantification, role of HBV RNA, role of HB core antigen in the blood, all these advances that are taking place, newer drugs that are in the pipeline. Now from here on, it's only Viva. So we can help you with what is to be discussed as far as the clinics are concerned. And from here on,
what will be your take on a person who has not developed cirrhosis and he has HBV infection and his viral load is high? So how long will you continue the antiviral therapy with Incubation?
Sir, I will continue. Usually look for HBsAg conversion. Ideal will be HBsAg conversion, which will not be the case in most of the patients. So
this patient may convert, doctor, because he's acute.
Yes,
so actually, what you should do in this patient is, because he's cirrhotic, we are treating. Otherwise, in 6 months' time, if it was acute, I would actually wait. Because DNA will be high. And you will be in for a surprise. At 6th month, you find that HBsAg is negative and E antigen. We had patients. They came as acute hepatitis, but actually, they were patients who naturally cleared at 6 months. And because he was 45 years old, we just started him on Incubation. But at the end of 6 months, so in acute hepatitis B, just remember this, acute insult, always see that I would wait for 6 months, even if it's 1 crore, but here's he's cirrhotic, so I would treat. Non-cirrhotic patients, just see that his enzymes come down, jaundice comes down. At the end of 6 months, that's when you call it as chronic HBV, no? You call it as chronic HBV only when it's more than 6 months. So this question again will be asked, do you think it's acute? Is it acute on chronic? Or you think it's a chronic with reactivation? All these Viva questions will be asked at this juncture. And according to Dr. Sareen, there's nothing called acute. Everything is acute on chronic. No, he always believes that. And to confirm that this is cirrhotic patient, no problem. But they will ask you in a non-cirrhotic. So then you may have to do a liver biopsy for confirmation and then decide on the treatment. Okay, so please read up everything about Bebino 7, read about antiviral drugs, hepatitis B management, read everything on the advances that are taking place, new terminologies, new markers for hepatitis B virus infection, all these. Dr. Viti, you can summarize and conclude.
Dr. Manmohan, what is the final diagnosis? Now we have all the answers ready. What's the final diagnosis?
It was acute and chronic liver disease, respirating human being with hepatitis B virus.
Hepatitis B and chronic liver disease?
Status quo.
With underlying chronic liver
NAFLD related.
Yes, NAFLD related. Chronic liver disease being NAFLD related.
Okay. Did you understand that why both the faculty resisted the temptation to diagnose HCC, HPLC, all those things? Yeah, but carry on.
Okay, yes, sir. Sir, actually,
No,
one doubt, sir. Regarding the details of the surgery, laparoscopic surgeries, ma'am. How to start with the history, ma'am, first? Because now chief complaint
all that you mentioned is fine, you know. So you start by saying patient on February 2nd of 2022 underwent laparoscopic sleeve gastrectomy for obesity, as was informed to him by his operating doctor, for approximate BMI of so much, because you've got the weight, you've got the height. Mention that. And patient remained, and he was found to have an underlying chronic liver disease during the surgery. So that information we have. Patient was asymptomatic thereafter. Instead of taking 4.5 months, bring it to your incubation period. It will help you for 50 to 150 days, no? So bring it to your incubation period. Within 3 to 3.5 months after the surgery, patient noticed sudden onset of jaundice, which was preceded by some anorexia, nausea. Because you can always build up. No one is going to get up and ask, did you have anorexia, nausea, vomiting? No one is going to get up. But if you just build up in that manner, it's easy for you to discuss.
Okay.
So you have to mention sleeve gastrectomy there. Otherwise you have to biliary enteric fistula will all present like this. And then he took CAM, and then for me it was very, now that bilirubin will not come down that easily because CAM is still acting on that MRP2. MRP2 is the conjugated bilirubin that gets excreted to MRP2. What really happens with CAM is it gets just stuck like a Fevicol, you know. It just does not move in. But if his jaundice is due to hepatitis B, he will do very well. He will respond. Jaundice also will come down. And for heaven's sake, just because patients got ascites, do not bring in Butchiari in all the cases. This particular case, why should a person get Butchiari? No? And as Dr. Viti, there's no drug history at all. Even we do say 20% do not disclose. But you've taken the best history, and as far as there's no disclosure, he's not on herbals, he's not going to gym, he's not taking any herbal preparation. So we're very clear. DD will not come as a DD. HCC will not come as a DD. It's an excellent case for discussion. I'm very happy that you will. Please read post-gastric, bariatric surgery, the endoscopic maneuvers, complications, read everything. Because if one of the examiners is an endoscopist, he'll be hanging on that. Someone who's more towards clinics, he'll hang on to that. And each one will be pouncing on you, no? Okay, so I'm giving you the worst description, but the best happens in the exam. So don't worry about that. All right? Good presentation, just improvise. Next time, on Tuesday onwards, just for your training purpose, because I think exam should be next month or so, just see that you just bullet. We will be attentive as examiners. That's why today I told Harish, don't tell us anything about the case. Neither we knew, neither I knew. So it was easy for us to discuss. Okay. No, the discussion was very easy because we were with you as examiners, true examiners. You understood? So just bullet it and start speaking well. Start presenting and speak well, and we will be attentive as examiners, and we'll keep asking these questions. All right.
Okay. One more query, ma'am. Are we allowed to see if the patient shows the reports, ma'am? Can we tell in the history, or we are not allowed to see the
nothing will be there with the patient. They will take off all that history, scan, and nothing will be off. Nothing will be with the patient. But not if you go to CMC Vellore for DNB exam, they're all, very, they're all well-read, literate. So they'll say, doctor, I remember one exam, the patient says, I have primary sclerosing cholangitis and I've come for intervention 6th time. That's it. So your history starts from there and your discussion is only management. You understand? So,
yeah.
So,
There was in the chat box whether we should tell the diagnosis arrived by the patient. I think there is no confusion. The patient is very clear about his diagnosis, like sclerosing cholangitis, cirrhosis, IBD, Crohn's, etc. I think you have to discuss like a consultant.
You have to speak with the consultant.
Yeah, that's it.
Because he's coming to you for a second opinion. He's coming to you for a better opinion. That's all. And supposing a person says, I'm HPV positive, you will start with that. I'm HPV positive, and what is the concern thereafter? All right.
Yeah.
Any other doubt? I don't know.
We won't be much concerned about the diagnosis in that particular patient. We'll be concerned more about the investigation and management. Then the case will be hovering around management. If the diagnosis is already out. Okay, that's the difference. And the most common case in the ward, day in and day out, is cirrhosis of liver with the decompensation. So if you have a case in the examination, it will be most likely kept, and you have to be absolutely thorough because that's the most common case you are seeing in the inpatient for the last 3 years. The examiners will not be happy when we make mistakes regarding. So please read up cirrhosis, present more cases of cirrhosis decompensation because that's very important in the examination. Okay. And there's a lot of things to read today, especially bariatric surgery, biliary anastomosis, and other things.
And HPV. And HPV. Yeah.
Hepatitis B, newer things. You know, all these things. Okay.
Shubhankar, what's the doubt? Quick, we want to conclude. Shubhankar, speak out fast. What's the doubt? Shubhankar? Just speak out, you're muted.
Hello, ma'am.
Yeah, please tell.
So I wanted to ask, if the patient is so obese with a BMI of around 40, do we comment on mild ascites? Because I think it will be very difficult to appreciate the mild ascites in such patients.
If the girth is, like we had a patient today, so what I would ask is there a gain in weight? Today we had a patient who's obese. So what I told him today is, he came, the patient came today saying that my girth has increased. So I said, just check the weight. If the weight has increased, it's a true ascites. If the weight is not increased, that's the only way to know whether it is obesity with or without ascites.
Yes, sir.
Understood?
Liver, spleen, other mass, all those things will be very difficult to assess in a patient with obesity. Okay. Here this patient also on mild ascites. So if the investigation findings and if the clinical findings correlate, which is unlikely to be detected, then examiners will be in fact feel very angry, annoyed. Because that means you had some background information. Okay.
No, this patient had a tapping, no? So it was easy.
Yeah.
This patient had paracentesis, so there is no problem.
Yeah. Otherwise, if there is ascites which is clinically undetectable, and you go on some examination, do some background information for heaven's sake, never say. Okay. What background information you get from others, not from the patient, from other sources. Okay.
If the registrar tells or something, please don't accept it. Have a clear. The best, like today, what we discussed is the best situation. When none of us know what the case is, and we go along with the candidate, and this is how the discussion should take place.
The examiner, the faculty had no idea about the case.
Exactly. So next presentation will also be by any postgraduate, and we'll take 2 or 3 candidates in and around the PG to discuss. And we are not going to prepare PowerPoints, no more PowerPoints from our side.
Okay. 8 o'clock. Okay.
8 o'clock. Thanks, VT. Thank you so much for participating. And you've done a wonderful job. Just improvise on your history, Manmohan. Just improvise. Think of all that we said. Bring the present. Don't mix the past. All that we discussed in detail. This was one of the sessions when I really wanted to improvise on the history taking. Okay.
Okay. Thank you.
Lots to read. Read Bevino, read Hepatitis B.
Only thing is that we want to reduce the content. To save time. That's all. Otherwise, it was an elaborate presentation.
Yeah.
Okay. It's a very good presentation, but for exam sake, it and make it concise. That is the message we want to give.
And do not waste time writing, I'm telling you. Just bullet it. All of you are very good in your language. And no one, I'll tell you in the exam, no one makes fun of the language. Medicine is one subject. where you don't have to speak good English. You understand? Broken English is also fine. To such an extent, in one of the Jaipur candidates, we told you can even speak in Hindi because all of us knew Hindi. To that extent, the examiners come down. So please don't waste time writing long histories. Just bullet and expand. Bullet and expand. You can expand. You know under what? In that you write onset, progression, aggravating factors, relieving factors, associated symptom. That's all. And then you keep expanding. And keep the paper in front of you and keep speaking. Manoj Sahu no meeting from Cuttack. When I went as examiner for him, he didn't carry even paper. And he was speaking as though he was talking a story, you know. And he said a beautiful history because he was thinking and speaking one after the other. That's the best history. Instead of reading, don't read. The exam evals, don't read. Just have the bullets in front of you and keep expanding. That's the best way to analyze. And always the person opposite you does not know anything about the case. So you're describing everything. So it was very good. That's why I told Harish not to tell anything about the case today. We both were listening. We listened to your story and then we discussed the case. So always think that the other party does not know anything about the case. And please, for heaven's sake, don't take clues. Don't take clues from any of the registrars or any of your colleagues. Just go with a clean mind, will do the best. And they'll appreciate the examiners. As I told you in the beginning, we're not interested in the diagnosis, only the approach, just the approach. Okay?
Actually, the fact the examiners can find out, you know, because you have only one or two DD and you hover around it. You will not expect a list of differential diagnosis. And we will have a list of DD which is 5 or 6, and you will only have 1 or 2. And so we know, whatever we suggest, you won't increase the list of differential diagnosis. You won't expand upon it. So we immediately know that. Finally, those 2 diagnoses which you told will be the final diagnosis, as evidenced by imaging or something. Then we immediately get that clue. So please be very careful. Unless you are in dire soup, never ever take tips.
Don't take tips. Like today we had 2 consults. I'll just tell you very briefly. The history was not like liver disease. So I just told Bhargav, it will be something in the lab report. So what can go wrong in the lab report? It will either be an HBV or an HCV. Patient is being referred to us for opinion. So when we got no history of liver disease, I said it's something in the lab. Either the lab biochemistry is abnormal or a B or C virus is there. And lo and behold, HbSAg was positive. That's it. Finished. You understood? So you get those incidental cases, you know, incidental HbSAg positive. The history is all negative. Diabetic, nephropathy, diabetic or neuropathy, and we were called to give an opinion. So we were just discussing, I said it's got nothing to do with the liver disease. You will either be having AST-ALT elevation with a cholestasis, or you'll be HbSAg or HCV positive. Look, it's so simple it is. It's so simple to understand. Okay? So all the best. You all do well. All right?
Okay, all the best.
Thank you, BT. Thank you so much, BT. Thank you so much for being with me. Yeah. Harish, thanks a lot.
Thank you.
Thank you. Tuesday, 8 o'clock, no? Tuesday, 8 o'clock.
8 o'clock.
Thank you. Thank you, sir.
Thank you. Good night.
Thank you.
Good night.
Good.